Thank you so much for joining us back, folks. We're going into the last component of our public meeting, and we are delighted to have 4 companies join us for our innovation spotlight, I should say, rather. We have slides to go along with their 5-minute presentations, and Dr. Apley is going to walk us through.
Thank you, Joanna, and welcome to our presenters. Welcome back to the council. We have 4, and we've allocated 5 minutes per presentation. So first, I would like to start with Tuck Stibich from Xenex.
There we go. Yes. Hi, thank you for having me today. I'm an infectious diseases epidemiologist. I'm a fellow of IDSA. And what I focus my work on right now, and where I think there's this amazing opportunity for antimicrobial resistance, is on surfaces and healthcare. And if you look at the slide here, they're happy to see it's working. It'll flash every 6 seconds. And every time it flashes, that means somewhere in the world, one of our robots has just completed a disinfection cycle. And so we've got about 1,000 robots deployed all over the world. So every 6 seconds, we disinfect somewhere. The reason I'm really focused on surfaces is because I do think there's an opportunity there. What we know from studies in hospital setting, there are these called blacklight dye studies. So you take a fluorescent marker, you mark a surface, and then hospital cleaning comes in, and you mark all the high-touch surfaces. These are the bed rails, the tray tables, things that are touched frequently by patients, by healthcare workers, and you mark them with this invisible dye. Housekeeping comes in, cleans. They leave, you take a black light, you look to see where they're left behind, and consistently over time, over and over, studies of 10,000 rooms, 50% of the surfaces are touched. So that's 50% of the high-touch surfaces. This is between patients are even touched. Of the ones that are touched, about 60% are disinfected correctly, meaning the right dwell time, the right pressure, the right chemicals, and 40% are disinfected inadequately. So this is a huge opportunity. But what clearly happens, and what we tell EVS, the housekeepers, what we tell the EVS workers is they've been given a humanly impossible job. They have a really limited amount of time. They're supposed to make this room look beautiful and pathogen-free. And that's just not possible. And we also like to tell them the pathogens have evolved, but their tools really haven't. They're still using mops and buckets and wipes. So that's where we come in. We like to think we want to give them a new tool. We want to be able to fight these pathogens that have evolved, that have become so serious, these antimicrobial resistant pathogens, that we want to give them a new tool. And what it is it's a high power, it's a pulse xenon UV disinfection robot. So we're going to automate this task. We're going to try to automate the task of disinfecting the room and removing these pathogens. We know that the pathogens persist from patient to patient. We know that things like Acinetobacter and certainly Clostridioides difficile, C. diff, can be in the environment. C. diff can be in the environment for up to 6 months. The spores, very difficult to remove. We know this is a problem. So this is the intervention that we've designed. This is it takes 5 minutes per position. So a typical hospital room, 5 minutes on one side of the bed, 5 minutes on the other, 5 minutes in the bathroom. And we've really incorporated that in with the workflow of the EVS workers so that can be implemented well. We're very concerned about resistance. I'm very concerned about resistance. So we've done those tests. We've been able to go 25 cycles out to show we're not going to create resistant organisms. We also know we're not going to damage the materials in the hospital room. And as I've said, we're in about over 1,000 hospitals, about 130 government hospitals, including a substantial number of VAs. We have about 45 studies published. And we've run, the robot has run, and I really, really like this number, more than 35 million disinfection cycles. So it's automated, it calls in, it lets us know what's happening. And we found in one study at MD Anderson that we're about 22 times more effective than standard housekeeping at removing pathogens from the environment. So housekeeping comes in, they do their job, and it's just humanly impossible, and we need to automate that. We talked a little bit in the last session about kind of human error, human behavior, all of those factors. So this is a robot to take one of these critical components away from human error area. So when hospitals use this, what they find is, we're able to integrate into their process. We don't slow down room turnover time, which is obviously very important. We're able to elevate the EVS worker. So now they feel like they're operating the robots. We bring them in, we name the robots. They feel like they're part of the infection control process. And we really want to incorporate that in there to give them more pride in their work and that workforce and increase their training and capacity by giving them this new tool. What we typically find is when we launch these robots into hospitals. They might start with one or two. And as the hospital sees the benefits from a workflow standpoint, from a financial standpoint, return on investment standpoint, as they see those benefits, those programs expand. And the cost of the robot is acceptable to the hospital. So as that, they want to expand that program and make it larger. Last things are, I would love to talk with any of you about this. In the time of this presentation, we've done about, 50 disinfection cycles somewhere in the world. And that's really our mission, is to partner with our hospitals to reduce the risk of these pathogens, to help them achieve their goals of increasing patient safety. And the last thing I'll leave you with is a quote from the AMR threat report from Robert Redfield, which he said, "We need to adopt aggressive strategies that keep the germs away and keep infections from occurring in the first place." And this robot, by elevating what we do to surfaces where we know there's a problem, we know 50% aren't even touched, that is our aggressive strategy. Thank you.
Thank you. Next, from N8 Biosciences, we have Carl Genberg.
Thank you very much. My name is Carl Genberg. I'm the Chief Development and Scientific Officer for N8 Biosciences. Our medical device subsidiary is N8 Medical. It's an honor to speak to you today. 20 years ago, Dr. Michael Bell of the CDC authored an article, Biofilm, Clinical Perspective, in which he advocated for a fundamental shift in thinking to address the important role of biofilm in medical device-related infections, which account for more than 50% of all hospital-acquired infections. Any strategy to combat antimicrobial resistance that fails to address biofilm is missing half the problem. I am pleased to report that our innovation, the CeraShield biofilm coating system, now makes biofilm prevention on nearly all indwelling medical devices possible in the near term, including ventilator-associated pneumonia. Biofilms are slime-like aggregations of millions of CFUs of bacteria, fungi, or both. Biofilms, unlike their planktonic counterparts, are inherently resistant to conventional antibiotics. Biofilm is synonymous with antimicrobial resistance. Preventing biofilm fouling of medical devices can save thousands of lives and billions of dollars of preventable costs for added days in the ICU and antibiotics. NIH estimates that HIIs add approximately $30 billion annually. In the case of ventilator-associated pneumonia, each new case is 8 days in the ICU with mechanical ventilation at an added cost of $32,000 each. We are indebted to Dr. Paul P. Savage's pioneering research in innate immunity. Dr. Savage, professor of chemistry and biochemistry at BYU, has developed a novel class of compounds called serogenins, which are synthetic non-peptide mimics of endogenous antimicrobial peptides, or AMPs. AMPs, such as LL37, form the basis of our body's own innate immune system. They are safe, broad-spectrum, fast-acting, and are active against bacteria, fungi, and lipid-enveloped viruses, such as COVID-19, orthopoxviruses, such as monkeypox. Patients who are immune-compromised are at highest risk for HAIs. AMPs have existed in nature for millions of years and do not induce mutational resistance. Published research shows the same is true for serogenins. We've in-licensed this technology for BYU for use in drugs, addressing the gut microbiome and cystic fibrosis, and in coating medical devices. The key benefits of serogenins are, next slide, please. Next slide. There we go. They are able to both eradicate and prevent biofilms. On the left-hand side, you see an endotracheal tube segment subject to Candida auris and Pseudomonas. And on the right-hand side, another endotracheal tube segment coated with our coating, which you see is entirely clean. They are active against escape pathogens and MDR strains, including carbapenem-resistant, colistin-resistant Pseudomonas and Acinetobacter, as well as chlorhexidine-resistant, also active against Candida auris and COVID-19. They can sequester and inactivate LPS better than polymyx B. They do not induce mutation resistance after 30 serial passages. Rather than adding costs, they save money. by preventing extra expenses that would otherwise be prevented by stopping the infection in the first place. At very low concentrations, serogenins have no drug-like activity but act as anti-fouling agents when coated onto or incorporated into indwelling medical devices. This technology is supported by over 100 peer-reviewed journal articles from researchers around the world and 32 issued patents. Our first product, as I mentioned, is our SeriShield endotracheal tube, which will be indicated for use for prevention of ventilator-associated pneumonia in ICU patients who require mechanical ventilation. FDA has designated this device as a breakthrough device. It is recently approved for use in Canada and Brazil. Next slide, please. We did a first-in-human study in Canada, and we showed a 97% reduction in colonization of the endotracheal tubes in patients. Of the 52 endotracheal tube aspirates, only one was colonized, and that was staff at day 10. Compared to historical literature, you would expect 70 to 80% of endotracheal tube aspirates to be colonized. Next slide, please. Most importantly, these compounds do not induce mutational resistance. Compared to colistin here, which you saw after 7 or 8 serial passages, you have very high MICs. There's no increase in the MICs over 30 serial passages. Thank you for your attention.
Thank you. Our third presenter is from Vivli, and it's Rebecca Lee. Thank you.
Hi there, my name is Rebecca Lee. I'm here representing the AMR Register, an innovative platform for sharing of industry surveillance data. This was developed by a nonprofit that I lead, Vivli, a global nonprofit whose mission is really focused on data sharing. We launched the AMR Register after being given an, can you go back just a minute? After being given an award by the Wellcome Trust, who provided the seed funding for this effort. We launched this platform really to detect trends in multi-drug resistance over time, inform national and international policy and antibiotic stewardship, as well as allow modeling of future resistance trends. Next slide, please. We're really delighted to have an esteemed scientific advisory board who advises us on the development and outreach for this platform. We are this SAB is chaired by Mark Mendelson of the University of Cape Town. Next slide, please. The data that's includes post-market susceptibility surveillance data and are collected using standardized methodologies and are provided at the raw MIC level. We're very much grateful to our biopharma AMR steering committee members who contributed these valuable data and are shown on the right. On the left are shown the metrics from the surveillance data sets provided to date. You can see there are from over 81 countries, over 925,000 isolates, and testing approximately 69 antimicrobials. These include data that include approximately 40 from 40 LMIC countries. Next slide, please. Since our launch over the summer, approximately 2 months ago, we've had a number of researchers that have started to access and analyze the data that is on the platform. So how it works is researchers come and conduct a search for studies on the platform. It can be found, it's live at amr.vivli.org. And then they access the susceptibility surveillance data, conduct their analyses, and go on to publish their results. It's an easy to access and conduct their search. And in closing, we really look forward to expanding the scope and coverage of the register in the years to come and see the utilization increase over time. I'm extremely happy to be here to make you and others aware of this valuable and innovative resource. And it's really our hope to make the AMR register data as widely and broadly available to others, to researchers and policymakers as a universal, free, and easily searchable platform for public access as a significant step forward to advancing antimicrobial stewardship. So I'd really love to connect with any one of you or those on your team who would like to learn more. Thank you very much.
Thank you for your presentation. And our last presenter is Greg Merrill from Adaptive Phage Therapeutics.
Great, thank you. I'd like to thank everyone on the PACCARB for your passion and your work in advancing efforts to address antibiotic resistance. I'm Greg Merrill. I'm the CEO and co-founder of Adaptive Phage Therapeutics, also known as APT. APT is a clinical stage biotech with 100 employees and broad government support that's focused on addressing the global crisis of AMR. Our headquarters and manufacturing facilities are based in Gaithersburg, Maryland. Bacteria are constantly adapting to their environments. The first day a new antibiotic is introduced, its coverage is at its peak. Unfortunately, the range of coverage will decrease over time, as the range of all antibiotics is always diminished as bacteria evolve resistance. It has happened every time a new antibiotic has been introduced. Unfortunately, as bacterial strains emerge that are resistant, the antibiotics are fixed to target the old strains. This is a guarantee of obsolescence for each new antibiotic. And development of a new antibiotic takes a decade at best, typically 15 years. And while resistant bacterial infections consistently emerge within 2 years. Antibiotic stewardship is an effort to prolong the useful life of antibiotics, but has the unintended consequence of depressing the market for these drugs and thereby diminishing commercial incentives. For these reasons, it has become clear that antibiotic development has been following a failed business model. Next slide. Bacteriophages, or simply phages, are narrow-spectrum, natural bactericidal agents. An aggregated phage collection called the APT Phage Bank now exists that covers all bacteria within CDC's most serious and urgent biological threat categories, commonly referred to as the escape pathogens. There are now no escape bacterial isolates that cannot be covered with APT's Phage Bank approach, even for isolates that are otherwise completely antibiotic resistant. This phage library concept was initiated at the National Institutes of Health and is now being advanced and expanded with aggregated phage collections from biodefense labs of the U.S. Department of Defense, including the Naval Medical Research Center and the Walter Reed Army Institute of Research, as well as internal phage discovery initiatives at APT, and through collaborations through several academic phage research labs in the U.S. and abroad. And clinical development of APT's Phage Bank has been funded from support from the Defense Health Agency, NIAID of the NIH, the Mayo Clinic, as well as the AMR Action Fund and other large VC funds and healthcare systems. The APT Phage Bank is paired with a phage susceptibility test that matches a patient's bacterial isolate to lytic phage within the collection, analogous to an antibiotic susceptibility test, or AST, for matching antibiotics. Global scale commercialization of the PST is being advanced in collaboration with Mayo Clinic laboratories. Next slide, please. Perhaps the most profound aspect of this approach relative to overcoming AMR is that as inevitable resistance to a phage is identified, additional phage can be found, making the phage bank rapidly expandable to cover any resistant pathogen. This coverage expansion process, including the necessary regulatory reviews, has been demonstrated to be accomplished in under 120 days. That's 4 months versus over a decade for traditional antibiotic development. Next slide, please. APT's Phage Bank, in success, will be the first antimicrobial ever developed that does not decrease in its coverage over time and does not require or benefit from stewardship. APT's Phage Bank has been used in over 50 compassionate use EIND cases in which standard of care antibiotics have failed and is currently in phase 2 clinical trials. Thank you.
Thank you, Dr. Blazer. And I thank our panel for your presentations. And I'll turn it back over to you, Dr. Blazer.
This session with the innovation is finished. That we don't have a question and answer period after this. So thank you everyone for coming. We're now going to we're winding down the meeting, and we're going to conclude with a round robin again, as we did successfully yesterday under Dr. Apley's lead. I'm going to innovate, and that is that instead of going to the right, I'm going to swipe to the left. So, Dr. Plummer, and we're going to end with Dr. Julie Simzak, who's going to make some comments about communications, which is going to kind of get us in shape for our next meeting. Thank you. So, Dr. Plummer.
I did not move here intentionally to be first again. So, by the way, I don't have many innovative thoughts, so I have to go first. I think one thing that struck me today, and it probably relates to what Julie will talk about, and we've talked about it multiple times, is just the kind of human dimension of all of this. As we've talked about, number one, the workforce issue and fatigue there associated with the extreme draws on everybody's attention, but also the behavior change, the communication, the messaging, the relationships that those healthcare workers or farm workers have with the folks or animals they're taking care of, and the potential risk for disease transmission there in the hospital setting or in the farm setting between caretakers and those being cared for. And so I think that's one thing that I leave here with, that as we think about challenges to put into the report, how do we build those types of response networks in that address those human dimensions?
So actually across the 4 sessions, there were so many commonalities that I think we share, whether it's in the human or the animal environment. So I just wrote down some key words, some which were already mentioned. So workforce across all levels, cross-training, incentives not only directed at people to either get them to enter the profession or to stay in the profession, but incentives for treatment, vaccines, and also for diagnostics. You don't want to go into the field if it's going to be a low return product. Timely, cost-effective measures, communication, which is really key, across all levels, and how we present that messaging from the everyday person to the medical person. So it's a really big divergence. And what I thought was really interesting is that in our scenario, the animal portion is such a huge component of it. And I think people need to hear that. On the news, we hear about our hospitals are overflowing and all these people are sick and everything. But when there is that animal component to it, I don't think we would never probably do a good enough job to really explain what's going on in that part of the interface also. Rapid point of care diagnostics, infection prevention, definitely career awareness for that, and maybe some type of grant sponsorship to get more people to go in. Stewardship, very important. Inventory management from PPE to vaccines. Financial burden, so that's really across healthcare systems. It's across the workforce. It's across the food supply chain and everything that would happen with that. The clinical trials network, we do already have some of those already in place in the United States, and I think we need to think about how we can activate them really quickly. And as nicely mentioned, we have a huge gap in pediatrics, and I think that really needs to be addressed. Guidelines in general, we can have some ready that can be easily adapted to the situations. And then finally, some adjectives such as resiliency, sustainability, proactive versus reactive, disparities that we need to think about. And finally, as Arjun said, it's investment, it's in resources, and I think we have to gain back a lot of trust and rebuild everything after some of the craziness that we've had with COVID.
Well, Paul always goes before me, so I have nothing interesting to say as a consequence. I think, going back to the sort of the higher, 35,000 foot, because that's all we can afford to do in a report like this. I think as Jomana mentioned on the first day or yesterday, this is about a federal government response. So there are many things that ought to be done that we should see done, but they will not happen because of PACCARB. They won't happen because of federal government response. And what the federal government is best at doing is really changing incentives, and then it's good at funding. And then it's also good at sort of setting the overall tone for the response. All the action is going to happen on the ground, and it's going to happen very differently depending on whether you're in Florida or in Alaska. So it seems to be that there's a lot to be done on the incentive side, particularly this morning's presentations on innovation, especially in terms of product innovation. There's probably not going to be time to do a lot of product innovation if you truly have a fast-moving pandemic. COVID was unusual in that sense that we could have a vaccine, but in most cases, if we didn't have the antibiotic available before this pandemic, it's not going to happen during the course of the pandemic. And so, unfortunately for AMR, we're going to have to do all of that heavy lifting well in advance. And I think changing the incentives for everything, for the workforce part, will have to be the federal government that incentivizes the creation of excess capacity. It'll have to be the federal government that incentivizes the cross-training that happens in advance of a pandemic. It'll have to be obviously the federal government that, as Arjun's brother has now told us many times, that it'll have to be paid for well in advance. So I think if we focus on the incentives and the funding and where that really ought to go, that's a large part of what we can do in advance. And then we have to be realistic about how much you can actually do once the pandemic is here, because there's not a whole lot that can be done at that point. Then it's really up to as someone said, you can't create a health system in the middle of an emergency. Either you've created it before or it's not there. And hopefully we've created it before the next emergency.
So I was struck today by the huge gap between the innovation and the quick movement in technology, even virtual reality for, teaching, and not to mention all the stuff that we heard this morning, and the human interface, and the fact that the behavioral aspects, the workforce issues, the fears, the trust issues, which are not related to the federal government so much, but I think that there's such a huge gap that one of the things we need to do is figure out as a council, are there recommendations that we can make beyond incentives, the traditional incentive of financial, raise and pay or something, that can bridge that gap a little bit between our technology and our innovation technologically, and the fact that in terms of the social sciences, the behavioral sciences, and the workforce issues, we're actually probably in worse shape than we were before.
I'm going to hit on a little bit of what everybody said so far. I feel it's a game of and. What else can I add? Try to take myself back to being a product of the land-grant system. Was at 3 land-grant universities, working at 1 now, and that the federal government doesn't have to do everything. Federal government can leverage resources outside of it, and one in particular I'm thinking as a land-grant child is cooperative extension. It's in every land grant across the country. It's a 100-year-old system. It focuses on addressing public needs of farmers, ranchers, communities, youth, and families. They are trusted in the community where the federal government may not be. I mean, I live in Tennessee. They do not trust the government. They will trust extension. We have a presence in every county. Utilizing them and leveraging them to talk about, say, vaccine hesitancy and other issues is something we should be doing. And there's actually a program that they're working with USDA and CDC called Excite. And I'm not sure if people have heard of Excite. If not, we should maybe bring someone in at some point. It stands for Extension Collaboration on Immunization Tracking and Engagement. And it's a pretty cool system where, again, working with both CDC and their Vaccinate with Confidence communication campaign, and funded through USDA, they're out talking to people, families, about, educating them about the science, And I think leveraging land-grant universities in this aspect would really kind of expand the messaging from the government, which we really take to heart as where the knowledge base is. But the people out in the country don't necessarily feel the government are the ones who should be telling them this. So using a university to leverage that may go a long way.
Thanks for a great day again. I will also mention trust as one of my take homes, Julie. So as this relates now to having nimble guidelines, I think with the input from several societies and federal agencies, that we really do need to be nimble, but doing that will rely on trust between healthcare personnel and their managers. And so I think that's the challenge there. And then secondly, there was a question we didn't really quite get to, which was how can AMR and pathogen information sharing be improved during a pandemic to close workforce knowledge gaps? And as that relates to Project First Line. And I think AMR is really tricky because it can be complex to explain, especially to, in First Line, we want materials to be pretty simple, and it really does come back to doing hand hygiene. So I think we do need to think about how that messaging can be simplified. And we've done that. We've moved from COVID to monkeypox with Project First Line. So I think we do need to think about that for AMR. Thanks.
So the last time I was rounding on internal medicine at University of Michigan, my medical students started presenting their patients with haikus. And I was so impressed. I was so impressed. I couldn't do it. No matter how much time I had, I could never come up with a haiku. I'm going to try to have a haiku real quick and then try to explain it. Okay, so workforce needs some help. Cash rules everything around me, so let's advocate. And so, that going back to some of those common themes, I see, thank you for the haiku. I think we need to come up with, going back to the first sentence, what can the federal government do? That's going to be our recommendations, but then taking back with us in our different roles, whether it's to our professional societies, because some of the things that I heard today were that for antimicrobial stewardship, maybe some full-time equivalents or some kind of staffing rules that we could spread nationally would really help with the workforce. So we may not be able to do that, in our roles here on PACCARB, but we can advocate it, for it in our report, and we can advocate it in our individual roles. So you may not have gotten that from the haiku, but that's what I was trying to say.
Well, a very tough act to follow, and no haikus for me, or at least not intentionally. So, in thinking about this in terms of recommendations for the federal government, we should make sure that we are recommending prioritization on what should be done. It's very clear that there is a need for enabling agility and response and actions, and that's both in the peacetime as well as in wartime, but obviously particularly so for the wartime. One of the things that rang through very strongly today relates to prevention strategies. And I think that we need to return to prevention strategies and refresh the thinking about what prevention strategies mean. We should look at cost effectiveness, which is generally done, but also add in some weights relating to feasibility. And one thing I want to pick up on, and Mike aptly gave us the challenge to not be overly polite, but be challenging. And, we talk about vaccines as the end-all, be-all. And indeed, as a technologist, I'm very supportive of the role that vaccines can play. But I think there can be a disproportionate focus on certain technological approaches, such as vaccines, at the expense of those which might actually deliver broader benefit for patients as well as public health objectives. So I think we should consider how we can help inform the prioritization of the types of interventions that might be best prioritized, and not leave it as a case of the long list of nice things that we want to do, and the ones that might create a risk of overinvestment in spaces that can't deliver what is needed and starving those areas which actually can create real benefit. Thank you.
Well, the and keeps going, right? So I'm listening to everybody say risk. Mike, I think you brought that up yesterday. Risk, prioritization, critical incident stress, trust, community funding, inventory management. And the one thing that comes to my mind that I think hits both animal and public health is emergency management. One of the things we keep, what can the federal government do? We have FEMA, we have Homeland Security, we have lots of resources. We talked about PIO training, information training, how do we communicate? And a lot of that's out there, but we need to bring it all together. So in this session, the last 2 days, what I've really thought is, what does the unified command look like for this outbreak? And some of you are like, whoa, it's outbreak investigation, but we've got a unified command where you have your public health priorities and your animal agriculture priorities, and we've got to find a way to bring them together. So I think from this group, if you're not familiar with what your COVID incident command structure looked like, I'll encourage everybody to look at it. Because in Mississippi, we had at least 200 people in our incident command structure. But that's where we've got to be if we want to bring all these things together in a cohesive, collaborative manner. So, emergency management.
Jason Newland, Pediatric Infectious Disease Society. Great meeting. I thought today brought back a lot of memories of days gone past, but days to look forward and be prepared for. I think from a pediatric perspective, I reflect this as I'm not sure I know exactly all the things that the federal government can do in its response, and I might be struggling with that from a pediatric perspective. I think I can tell you I know access is a problem, and we talked about that today, and that's going to always be something I'll talk about. We didn't bring up school, and I know we've had meetings in the past that says, well, that's not really a federal government possibility, but it's hard for me not to think that in the days of COVID that we were all looking to the CDC about what to say next, which feels federal government to me. So I would say that, from a pediatric perspective, we need more access. We need access from testing, being part of trials, talking about our guidelines and those pieces and have them included. And I would argue that school is something that was missing here. And in an influenza pandemic, one place that influenza will spread and then lead to more AMR will be in schools. And to me, that's where the federal government should probably be, despite the fact that the states might take and do something differently.
Chelsea Shively from USDA APHIS. And as I was thinking about this meeting, one thing I can confidently say is that APHIS is really good at animal disease responses. We've heard a lot about the HPAI outbreak that's going on right now. I've been getting emails every day asking for volunteers to go deploy for that. We also learned that we could pivot and help with a human health response with the COVID-19 pandemic, both by leveraging our laboratory capacity through the NALM labs to help with human health testing. And I was one of the veterinarians that got to stick needles in humans. So I had a lot of fun doing that with vaccinating and being a part of that effort. We also have a lot of activities that we do to address antimicrobial resistance. And what I heard over the last couple of days is that we need to do a better job of integrating those things and looking at how we're responding to animal health and animal health emergencies and how we can incorporate some of the AMR work that we're doing. And I just say that I look forward to being on the working group and providing the perspective of USDA APHIS moving forward with the recommendations. And trying to find ways that we can collaborate, because I think we heard already that the U.S. government can't do this alone. The report is to give us some recommendations, but we need all of your help to be able to reach a broader audience. Thank you.
Thanks, Michael Craig, CDC. I think the thing that I'm left with after today is, again, focus on prevention. And, you can't talk about prevention without CDC, wanting to second that or third that. And I think the thing that we always have to come back to is that we cannot treat our way out of an outbreak. You can't treat your way out of a pandemic. You have to stop transmission. You have to stop spread. You have to prevent it. And that there's a lot of modalities to do that. And quite frankly, I think we need to invest in all of them. in more ways than we have been. I think the other thing that, the conversation came up today is on guidelines. And I think that is an area where, especially on the human health side, the U.S. is not in a good place. I think, do we have guidelines? Yes. Do we have a lot of guidelines? Yes. Are they user-friendly to our clinicians? I think we heard from them today, and they said no. And I think that would only be compounded in a pandemic scenario. And we need to figure out how we can do that better. And there's a lot of good examples from around the world of countries that have taken that on and had success.
Kyungmoon from NIAID. The major taking home messages for me are threefold. And we need firstly consistent and stable funding to support funding mechanisms to support AMR research so that we can have effective and necessary diagnostic, vaccine, and therapeutic products ready to go in a public health emergency. And secondly, a clear guideline for health professionals and public. And I need to tell you that normally NIH does not provide any guidelines, except there is some rare cases, such as for COVID-19, but we generate data to inform and develop effective guidelines. But lastly, better communication, not only among governmental agencies, but also among key stakeholders and with also the public, so that we can share the information and build the trust. That's it. Thank you.
Lynn Philby, HHS Office of Global Affairs. A couple of things struck me. I often think of AMR as the day job, and the pandemic coming along is the emergency overtime. And I think something that stuck with me was the just-in-time example. We have just-in-time funding for our day job. We're certainly not going to have resources for that emergency overtime. And I think we've set some really nice precedent with AMR that we need to build upon. I was also really struck with Dr. Abo's presentation just a short time ago. She really highlighted what global efforts can bring to us, especially right now when we are negotiating a global international instrument on pandemic preparedness. I don't think we can forget that these connections that we have are just as important as the legally binding aspects of our efforts. And we can institutionalize those. We have really good fora out there, TATFAR, Global AMR Hub, the Global Health Security AMR Action Package. We can use those so people can pick up the phone and get the ground truth from their counterparts, and we should. The other thing is, it's not so much a reflection as a going forward. We have 2 years until there's going to be another high-level meeting on AMR at the United Nations. And as Secretary Becerra said last week, there's an opportunity. As PACCARB is thinking through what these really practical advancements are that we need for the US to be better prepared for the next pandemic, I hope we don't forget that we also have an opportunity to make those high-level recommendations that would be appealing to 194 countries sitting around a room negotiating what they should be doing together.
Chris Alshon, Sparta. So there were a number of things that really resonated with me over today's presentations and discussions. But I don't want to repeat things that have already been brought up, but a couple things that I think are really impactful, or at least to me, was ensuring that we have established the ability, the capability, the funding to evaluate new interventions during a pandemic, whether they're therapeutics, vaccines, infection control practices, whatever, but having, a, clinical methodology driven studies that would evaluate these interventions to see how they're working, that would allow us to be able to implement or even seek regulatory approval for these modalities during a pandemic, I think are absolutely critical. It showed that with the active trials, how critical that they were during the COVID-19 response in allowing us to be able to evaluate these types of therapeutics. these therapeutic interventions were absolutely critical. And I think that we need to have something like that, whether it's through, having established clinical study networks, having national IRBs, having established protocols, whatever it might be, but really ensuring that we have that infrastructure and those processes in place so we can rapidly turn them on during a pandemic. The second thing is, we brought this up. It came up yesterday. It came up a lot today. And it really is staffing, and it's surge staffing. I think a lot of us in here can attest that certainly for the first probably 18 months of the COVID-19 response, many of us were working 7 days a week, probably 14, 16 hours a day, and it was brutal. And I can't even. I can only empathize with what healthcare providers, what they dealt with during that time as well, and it's incredibly challenging. But with surge staffing, that means we can't just bring warm bodies into a new environment where they don't have the experience. They have to be trained up, and so that they're available when they're needed. And I was just trying to think about what does that look like? How does that occur? And there were some ideas about training college students. There was some mention about working with high school students. I'm wondering, we're talking about what can the federal government do? And I wonder if the federal government can put together, first of all, identify where are the areas where you would need a surge capacity, a surge staffing capacity. What are the different environments that can come in, whether it's, to help to ensure that ICPs are, well implemented, whether surveillance teams are well staffed, wherever in a hospital, wherever in the response you need the surge staffing, identify those areas. And then perhaps the U.S. government can play a role in putting together national programs that could be adopted by states and locals, that they can adapt to their particular needs so that they could, teach high school students and teach college students and teach people in the community. These are the skills that, that we need to be able to help augment our, our ability to respond to an event, how to administer a vaccine, how to administer therapeutic, how to take, temperatures, how to participate in the surveillance lab, whatever it might be. But, really, I'd say more simple tasks that would allow you to train up the community to be able to respond to an event, I think would be really helpful to allow us to have the staff necessary during a pandemic. So thank you very much, and really enjoyed the past couple of days.
So Bill Flynn, FDA, also a great day, and it's really hard to pick out one point. There was so many important points made today. And this is probably reiterating what others have said, but I guess one issue that did strike me is I think we've talked both about technology as well as sort of the human component of this, and obviously both very important. But I guess reiterating the sort of human component of this one that did strike me in terms of whether it's the workforce issues that Chris just mentioned, but also from the communication standpoint and what we've talked about in terms of how do we engage, how do we best collaborate, how do we educate, all those things seem to be so critical. And even if we can apply this new technology or find ways to expedite and move technologies into practice quickly, there's still the problem that if we haven't effectively communicated with folks, that technology may not be effectively deployed. So it does seem to be when looking at those, the critical nature of the human element of this. So thank you.
Jasmine Gunza with CMS. It seems that everybody has already touched on the salient features today. Great meeting. Guidelines are really important, and everybody has reiterated that. But Dr. Spivak's presentation today and Dr. Abo's presentation really highlighted that all healthcare in the end is local. So the local universities, the health departments, and the trusted community agents, they are the most important elements who will help in the dissemination of these guidelines. No matter how many guidelines the federal government makes, if they are not trusted and if they're not communicated properly by the people whom the community trusts, they will be of no avail. Thank you.
Mark Albrecht, BARDA. I mean, there's been a lot that's already been said, so it's hard to kind of build off of what has been said. But I think the one thing that struck me is the human element. Whatever recommendations are made to the U.S. government, we always have to keep in mind the human element during a pandemic. And that includes the healthcare workers as well as the patients themselves, and everything that flows down to them needs to be easy for them to implement, respond to, and utilize so that we can get patients out of the hospital and recover from an emergency.
Emily Wheeler, Bio. I want to go back to a theme that I've heard across both of these great days of meetings, in that what we do in the inter-pandemic period or the peacetime period really matters greatly. And especially as we think about vaccines and therapeutics that are needed to address the resistant threats, which was a lot of the focus of today's discussions. We truly need to invest today to ensure we're prepared, as Ramanan just articulated so eloquently a couple minutes ago, and to meet the needs of the future and really what we see today for the unmet needs for AMR. We need to continue to strengthen the pipeline. And I know many folks know, probably everyone in this room knows there are fewer than 50 candidates in clinical development to address bacterial threats, and fewer than 19 of those are active against the most threatening gram-resistant bacteria. So we know the pipeline's inadequate, and we need to be taking actions today to bolster the pipeline. I think all of the programs that we spoke about today or heard from our NIH colleagues, CDC, ASPR, BARDA, all of those investments are critically needed, and we need to maintain and strengthen all of those programs that help support research and development as well as procurement of these novel products to ensure that that physicians really have those innovative treatment options. But we need also to continue to recognize that additional measures are also necessary, namely by way of antimicrobial pull incentives that explicitly support antimicrobial stewardship, and also look at novel de-linked mechanisms that really benefit patients and are for the most resistant threats. I think that as this group was well aware, and that the PACCARB recommended and supported back in November 2021, the PASTEUR Act is a way to do that. That is a real new and innovative option. And I think that as we continue and as we think about recommendations that this council makes, I think we need to continue to recognize, not lose sight of the important role of pull incentives to stabilize the pipeline and provide the products we need for current threats as well as in a future pandemic situation. Thanks.
Hi, Libby Dodds-Ashley on behalf of the Society of Infectious Diseases Pharmacists. It's been a very informative 2 days as always, and I don't know that I have much to add to all the great thoughts and comments of the previous council members that spoke. So I think I'll just close by saying thanks for giving us a seat at the table, for giving time to hear about the workforce needs and the challenges going forward. As pharmacists, we're here and ready to help with guidelines, implementing them, developing new drugs, writing policies. We are excited to do this with you, and we can't wait to get the hard work started. Thank you.
Armando Nahum, voting member. I think today was another great day with another fantastic panel, which makes me wonder why PACCARB doesn't have a 4 or 5 day retreat. I just can't fathom that. I just can't fathom all of the great and innovative ideas that we could come up with. So people call me the devil's advocate and the pusher. So I'm in lieu of that, I'm just going to continue that path. The last time we met in person 2 years ago, Two words stood out after that meeting: communication and education. Today, those two words are still active in our conversations, but a third word has come up: trust. So in following Dr. Lillian Abel, not to be worried too much about what I'm about to say, whether it's politically correct or not, I really don't care. I can't help but think that our science has come behind politics in communication and education, and that cannot happen again. No matter what, science has to be forward. Patient safety has to be in the forefront. We need to create a safe pathway for science without being held back by outside entities. And if we don't address it, I'm afraid that the next time we have another pandemic, this country will experience a second American Civil War. Thank you.
Well, no pressure there. I have a couple things that are unrelated, I think. The first is on the Virginia Fate voting member. From the veterinary perspective, I think there are things that this group can recommend as it relates to federal response that has some impact on veterinary practice, but there are a lot of things that happen in veterinary practice where the federal government has no role or has a very limited role. There are no third-party payers. We don't have CMS telling us how to code or how to manage our hospitals. And so there's some limitations on, I think, what we can do and what we can recommend, and we need to acknowledge them, I suppose, in whatever we do recommend. So that's one thing. And then the other thing I was thinking about, it's a small thing perhaps, but in the conversation about guidelines and developing guidelines and who does them and how do we implement them, one thing that has come up before in other conversations, some of you in the room are academics or are former academics. Some of you are here as part of your day job. Some of you are here in spite of your day job. And so I think there's some, I don't know if tension is the right word, but I'm a clinical professor. I'm not tenure track. I never was, but certainly my tenure track colleagues are not going to get credit for sitting at this table. They're going to get credit for getting their name on a paper in a peer-reviewed set of guidelines. And so to me, that is not the only reason, but it is one of the reasons we have so many guidelines. Another reason is that the neurologists don't trust the guidelines that are for the cardiovascular surgeons, or the veterinarians, the equine veterinarians don't necessarily believe that the guidelines should apply to them that were written by the swine veterinarians. And so there's some things there that we can't necessarily address, but we should certainly acknowledge in terms of coming up with those, making them useful, and then implementing them, whether they're diagnostic or treatment or infection prevention guidelines.
Julie, we'll come to you last. You get the last word. Johnny?
I don't know what to say after all of this. One thing that I have thought of that hasn't maybe been brought up entirely is sometimes the basic science can't keep up with how fast things are moving and how much communication has to be out there. And that's one of the most important things, to keep everyone together, right? The communication. But for example, with SARS-CoV-2, we had to make assumptions that it was just like other coronaviruses that we did know about. Turned out those assumptions weren't entirely correct, and that was very helpful for the Clorox company. But environmental surfaces turn out to be not quite so important as, people get this virus through the air from one person to another person. And getting that message out after I'm sorry about the hand washing, but that really did help a lot for Salmonella and Shigella and stuff, but I'm not sure how much it did for COVID. And the environmental surfaces and sanitizing them, and there were companies that were spending $300,000 to fumigate their entire, factory floor. And I would just say to these folks, all that extra cleaning makes your employees feel safer coming to work. But what you do to prevent the virus from moving one person to another is what is going to protect your employees. But that basic science didn't move ahead with our communications. And then no one was listening by the time it did. And now we're facing the same type of thing with high path avian influenza, where we don't even know how that virus is getting into our commercial flocks. And what can we possibly do in terms of biosecurity unless we understand the basic science of how that virus is being transmitted from the wild birds into the flocks? So I don't know where I'm going with this, but it's one point that I did want to bring up. Thank you.
Thanks, Mike Apley. I'd really enjoy listening to everyone again, and I really, really appreciate the comments from the point of care. And I think whenever we get lost, we go back and listen to the people at the point of care. And they will tell us what they need, and they'll also tell us when we're full of it. At least a veterinarian will. And I've found that out a lot of times. Dr. Abbas and Dr. Redmond's presentations really brought home of what's been mentioned before. It's about people, that care's local, and it's about the people that do it, and that our guidelines and our infrastructure is all about supporting the people at the point of care, and hopefully we empower them, if you will, or enable them to achieve victories against AMR. And I think that feedback and monitoring needs to primarily come from the point of care, and outcomes. We've talked about outcomes before. And I think about our healthcare system. In my little hometown, we have an 18-bed hospital that is critical to that. And wonderful things happen there, struggle for resources. And then I also watch a system that can take my paramedic son and in 4 years, turn him from the guy who, with his partner, drove into the path of a tornado to bring out a heart attack victim, to someone who walked away from it. And he walked away from it not because a loss of compassion. He walked away from it because of what he termed it, the pedantic BS of dealing with it. The paperwork and everything else drove him out of it. And when we talk about the guidelines, when we talk about piling all this on, I also caught that today, that we have to be very careful we don't overdo that, and that they're usable, and all the guidance, all the records, all the monitoring, that we don't kill the compassion, because what I learned was that feelings of apathy and helplessness are also contagious. And we have to keep that in mind as a council. And so I'll just close with how much I appreciate the point of care input you all bring. Thanks.
Well, that's a hard act to follow. I'd like to reflect that with several other people in this room, I started on PACCARB in 2015, 7 years ago, 3 presidential administrations. I was thinking about some of the changes in these last 7 years, and I can think of 2 big changes. The first is our change in the view of AMR in its context, involving not just humans and animals, but now in terms of the environment, not just bacteria, but bacteria and fungi, not just the pathogen, but the microbiome and the context it's in, and the development of innovation and products, the ramping up of BARDA, many of the new products, the ideas about delinkage, much innovation, and also a growing sense of the importance of stewardship as maybe the single most important way to control AMR. It's the most complex, it's the most enveloping, but over these years, we've been moving in that direction. So that's the first big change, is the change in our view of AMR. And the second, of course, is the 800-pound gorilla, which is COVID. and how COVID has changed and is changing our thinking. And if we want to be successful in controlling AMR, we have to learn from COVID. We have to adapt to the new during and post-COVID world so that the kinds of things that we advocate make sense in that new context. Those who don't learn from history are doomed to repeat it. And so COVID is there, and it's an important teacher for us. And I also want to say it's just been a great pleasure working with so many passionate, dedicated people trying to solve this problem. Now we'll turn to Julie for the last words of this meeting.
Thank you so much. So as a sociologist, what I'm always thinking about is the collective and how we get the collective to act in our sort of the unified best interests of everyone, because that's ultimately what public health is all about. And I think it's been clear both in everyone's closing reflections and in the meeting today that responding to these kinds of dynamic, complex and multi-sectorial infectious disease threats that we need to pay attention to communication. And it's clear, and it's been sort of emotionally described, that while we need technology, data, policies, tools, scientific knowledge, we need to remember that in these crises, it's people who are getting sick, people who are providing care for humans and animals, people who are creating policy, people are making decisions in the face of emotional challenges, multiple compelling competing priorities, and that people are having to coordinate to work together quickly. And we also have to acknowledge, I think we've heard about equity, we've heard about access today, that social, cultural, and contextual variation is shaping the experiences that people have in these crises, and that the impact of these events are not equally distributed. We have to remember that. But for PACCARB, we have to think about what our mandate is, and we need to be able to think about what are the federal response actions. And as Ramanan mentioned earlier, it's incentives, but it's also setting the tone. And setting the tone is about communication. And so I would urge PACCARB that in future meetings, we should dedicate time to considering a theory and evidence-informed approach to communication. Acknowledge that it doesn't just happen, and when it does just happen, it can sometimes go awry, and that we can be purposeful about it. We have a deep bench of expertise in this country who know about how to communicate in such a theory and evidence-informed way that we can invite to help us to make sense of this. There are a number of topics we could include, such as the content of messages, such as the tone, the framing, and the rhetoric that we use. We also want to think about the characteristics of the messenger and how they're perceived, their own characteristics and their behaviors. We also have to acknowledge the multiplicity and the diversity of the audiences who we're communicating to, and that messages needs to be tailored. Today, we heard about patients. We heard about animal and human medicine clinicians. We heard about South Beach spring breakers. We heard about EVS staff. We heard about prisoners, legislators, lettuce farmers, and the lay public. And so all of those audiences have different beliefs, histories, interests, and addressing that is really critical if we want our messages to stick. We also need to consider delivery mechanisms. We heard a lot about technology-mediated information dissemination, and this can be incredibly powerful. We also have to be aware of negative unintended consequences, the impact of misinformation, and the way that algorithms shape what people pay attention to, but may not be the things we want them to pay attention to for public health purposes. We need to think about using implementation strategies to encourage the embedding of information in routine daily action. And so the guideline is not enough. We know that guidelines and evidence don't get into routine use without attention paid to that. And I think the field of implementation science could be brought to bear on that. And so in closing, I think we should focus on evidence-based tone setting, be bold and innovative in how we integrate the messy social and behavioral realities of these collective challenges into the federal response. And I look forward to continuing these discussions as a council.
Julie, thank you so much for teeing us up for our next public meeting. And we're gonna close this meeting with some comments from Joanna.
Thank you, Dr. Blazer, and thank you all for being with us over the course of these 2 days. We've learned a lot from each other, and we've learned a lot from even the presenters, particularly a sincere thank you to all of the presenters, our Innovation Spotlight folks that joined us today, far and wide to present their technologies. As you can see, the innovation is there, the technology is there, and we try to have these innovation spotlight sessions so that you can see that there is work being done at the startup level and even beyond. But I particularly want to thank the PACCARB team. This meeting was largely developed by Dr. Mark Kazmierczyk and Sarah McClellan, who's reached out to all of the presenters. I'm sure those names are familiar to you. The logistics and everything else has been handled by Ms. Haley Krem, support from Jennifer Adana, and with support also from Ms. Chloe Loving. So I just want to do a round of applause for the team. Did an awesome job. And just on that note as well, as Julie had indicated, there are obviously other topics as it relates to AMR and pandemic preparedness, which is why we've already slated January 24th, 25th as our next public meeting. It will be held virtually as we plan for then our final public meeting in sometime in March, and we'll confirm that and announce that on the website for us to gather back in person, present the full finding of the pandemic preparedness working group, and then deliberate and have a final vote for transmission of the report that comes out of the findings from these sessions to the Secretary of Health and Human Services, who then in turn provides the report to the President. And on that note, just to echo the ASH and the ASPR and the Secretary previously, we have the support of this administration. So the time is now for us to be innovative, as indicated, to be forceful, to really, really hit notes very hardly, because things may change. And that's what we can do as an advisory committee, is provide these recommendations and do the best that we can from a scientific baseline, informed by great subject matter experts, to provide that advice to the government. So I thank you sincerely. And lastly, we have a selection process that's open. It closes next week. So for those of you in virtual land and here with us that are interested in being part of this table, please provide your application, send in a note. You can email us at carb@hhs.gov. And with that, I close.
Thank you, Germana. I'd just like to finish thanking the panel, the staff, the presenters, and the audience. This meeting's adjourned.
Produced by the U.S. Department of Health and Human Services.